and then starts off by taking questions. And once the questions are all attended to, then the questions will be taken in tandem by both Dr. Sujin and Dr. Joban. And at the end, I will be closing the program with thanks and regards. Is that fine?
That's yes, perfect. Thank you.
Yes. Sujin, is that okay?
Yes, yes. You can proceed.
Yes.
Fine, it's fine.
Yes. I have a minute more to go.
Jacob, are you there? I think it is already 6 o'clock. We can start.
We'll start in a moment.
Oh, the meeting is being live streamed on YouTube. How nice.
It has already gone live, I think 2 minutes before.
I see, I see.
You have been to India previously?
I was in Mumbai a few years ago for a meeting, and that was the extent of it. I had a wonderful time.
Okay. You have never been to our place, Kerala?
No. No, I'm hoping to travel to India again as soon as I'm able.
Okay. Once the pandemic is over, I think you can consider visiting our place.
Oh, I would love it. I'm a big fan. And remind me, please, who's in the audience? Are they, is it overwhelmingly a neuroscience audience? Are there clinicians and basic scientists, or just clinicians?
I think it will be a mixed crowd. That means the staff in this hospital will be participating. So all of them are free to participate. So that will include general physicians and specialists and also students. It will be a mixed type of, mostly from the clinic, mostly clinicians only, and some students. So most of them will be from internal medicine or related specialties.
Okay, so we are about to start.
Okay.
So good evening and welcome to this international webinar at Believers Church Medical College and Hospital. Today, we have a distinguished faculty, an amazing person from the United States of America as our speaker. Boston Magazine top doctor of child neurology, professor of neurology at Harvard Medical School, director of pediatric applications at the Berenson Allen Center for Non-Invasive Brain Stimulation at the Beth Israel Deaconess Medical Center, co-director of the intensive course in transcranial magnetic stimulation at the Beth Israel Deaconess Medical Center, director of neuromodulation program, director of experimental neurophysiology core and co-director of clinical neurophysiology core at the Boston Children's Hospital. We have none other than Dr. Alexander Rotenberg, professor of neurology, Harvard Medical School. After completing his BA in behavioral biology from the prestigious Johns Hopkins University, he went on to do his MD and PhD at the Health Sciences Center at Brooklyn State University of New York, and went on to train further in pediatrics at the Mount Sinai Hospital, and then neurology, epilepsy, and clinical neurophysiology at the Boston Children's Hospital. He's a member of a number of local and national committees, professional societies like the American Academy of Neurology, American Medical Association, American Epilepsy Society, and also he's been in a lot of grant review activities, like being the research grant review committee member of the Hearst Foundation, Israel Science Foundation, Takeda BCH Alliance, and much more. He's also the editor in prestigious peer-reviewed journals like Nature, Journal of Neurosciences, Neurology, Physiology, Annals of Neurology, and many, many more. Recipient of the prestigious Dreyfus Perry Award in recognition of outstanding achievement in epilepsy research from the American Academy of Neurology, and also a gamut of awards under his belt. Dr. Alexander has 145 publications, 35 contributions to books, etc. Invited. Can you please mute your mics, dear participants? Numerous invited lectures, and also he's been mentoring umpteen number of students and postgraduates. It's a great privilege to have him in our midst. Dr. Alexander, it's a great privilege to have you. Welcome to this international webinar.
Wow, thank you very much for this kind invitation. I hope I can live up to the caliber of this invitation with our talk. So I won't belabor the point. I'll quickly jump to a shared screen.
Dr. Alexander,
and
if I may introduce the moderators, and then one of the moderators will hand over the session to you.
No problem.
Yes, thank you. Now, to moderate the sessions, we have our senior consultant of neurology, who trained in neurology at the prestigious Trivandrum Medical College, and he's a specialist in epilepsy and sleep neurology. He's an astute clinician and a brilliant neurologist, Dr. Jobin John. Sir, it's a great privilege to have you in our midst. Welcome.
Thank you. Before I start the introduction, I would like all the participants to keep their speakers mute unless prompted by the host. So once again, good evening to everybody.
Sir, one more moderator. Dr. Sujin Koshi is our other moderator, a brilliant clinician. He's a junior consultant of neurology at BCMCH, Believers Church Medical College and Hospital. He trained in neurology from the prestigious PSG Institute of Medical Sciences and Research, India, and he specializes in stroke, dementia, and headache disorders. Welcome, Dr. Sujin.
Thank you, Jacob.
Yeah. And now over to Dr. Jobin John to give us an intro of the topic and then hand over the session.
Okay. Good evening, everybody. So we have a distinguished guest with us to talk about the non-invasive brain stimulation epilepsy. it's not a new thing in epilepsy, but it has been evolving over time. So we have both TMS and direct stimulation of the brain. Both are being used.
Who is Justin P? Please mute your mic. Justin P, please mute your mic.
Okay, so here we use the electromagnetic principles to non-invasively modulate brain activity. As everybody knows, epilepsy is an abnormal synchronous discharge of the neurons of the brain, and it is to modulate those neurons that we use these non-invasive methods. We have a large unmet need in the treatment part of epilepsy, especially in developing countries like India. I think, I hope Dr. Rothenberg's talk will be a great advantage to us, especially when in resource constrained settings where we can offer help to patients who are refractory to the conventional modes of medical treatment of epilepsy. Once again, I welcome Dr. Rothenberg, and now, sir, the podium is yours.
Thank you very much for this opportunity. If okay, I'll share my screen. And,
please.
And again, the topic of conversation previous to this meeting that we discussed was non-invasive brain stimulation. And in putting the slides together, I thought rather than a survey of a multitude of forms of non-invasive brain stimulation techniques that are available to us, and these include everything from transcranial magnetic stimulation to transcranial direct current stimulation to focused ultrasound, to near-infrared photobiostimulation, etc. I would instead focus deeply on one technique, just so that we can have a somewhat in-depth discussion. And of the non-invasive brain stimulation protocols, the one that has realistically the greatest prospects of helping us both as a diagnostic tool and a therapeutic tool in epilepsy is transcranial magnetic stimulation, TMS. And so I'd like to focus the talk here on realistic prospects for transcranial magnetic stimulation to help us in a comprehensive epilepsy center where epilepsy is treated both pharmacologically and surgically. And so by way of introduction to TMS, oh, bear with me, but my, there. I would just like to start by discussing the basic principles of the technique. And please, let's make this an informal discussion. If anything looks too simple and too familiar, just tell me to move on, and I'm happy to very rapidly. But ultimately, the technique of non-invasive brain stimulation by transcranial magnetic stimulation rests on the principles of electromagnetic induction described by Michael Faraday in the 1800s. And every transcranial magnetic stimulator contains a few components that are common. These are a capacitor that charges to about 10,000 volts, a steel cable through which a sizable fraction of this stored electrical charge is discharged, and an electromagnet, which works very much like the first set of electromagnets described by Michael Faraday, where if there's an electrical current in an insulated wire, an adjacent insulator wire will also then have an electric current generated in it by principles of electromagnetic induction. That is, that wire A, for example, if it has an electrical current through it, will generate a magnetic field. That magnetic field will induce electrical current in wire B. And this was a terrific discovery because it enables focal and non-invasive introduction of electrical current into the cortex. And so, as a quick aside, if you're in London for some reason, and you want to skip the boring tourist attractions like Big Ben and Parliament, you can actually go to the Michael Faraday Museum and see some of these original artifacts. The mechanics of transcranial magnetic stimulation have not changed much in the 30 years that this technique has been available. That is, the technique still rests on generating a strong electromagnetic field, usually over the motor cortex, so that we can perceive that it has been detected by the brain because there'll be a measurable motor potential. In modern times, these are Gabby and Natasha, our research assistant and secretary. The distinction is that an operator is able to also observe where the electrical current is landing on the patient's brain by coupling the electromagnet with a frameless stereotaxy MRI, a stereo camera that keeps track of the position of the patient's head and of the magnet, so that the operator can see where she has stimulated the patient's cortex. Now, just very quickly about the basics of the electromagnet. A conventional electromagnet in TMS, as you can see, can appear relatively large. It's about the size of the palm of a hand, typically. But inside this magnet, these are X-rays of representative magnets, are sets of conductive windings that, depending on their configuration, can generate a relatively focal magnetic field. So that the focused field in a magnetic stimulator that's the size is the one depicted here, can actually be about the size of a fingertip. And the reason for that is an innovative use of what's called a figure-of-8 coil, where the electrical current within this magnetic stimulator casing runs in two opposite directions in the two lobes of a coil that's configured to look like a figure of 8, so that the current sums at the center and falls off with the periphery. And for this reason, a figure-of-8 configuration, which is the most common one that we use in TMS in modern times, can provide a relatively focal stimulation of the brain. So for practical purposes, what this translates to is that we have a way to non-invasively induce electrical current very focally in the cortex, focal enough, for example, to stimulate just about a fingertip size of the cerebral cortex. And the practical embodiments of this kind of stimulation are made still more precise when we use frameless stereotaxy. So frameless stereotaxy is something I just mentioned. What it involves is a stereo camera with two lenses so that the computer can compute the position of the stimulator and the patient in 3 dimensions, and a feedback to the operator in the form of a monitor so that the operator can observe where the electrical current is landing on the patient's cortex at any one time. This is another example of what the operator actually sees and a representative participant. Now, the practical use for this kind of setup, where the operator applies electrical current to the patient, a computer notes where in the patient's brain the electrical current is applied, and at the same time, the computer records an electromyogram, an EMG signal from a plurality of muscles, is generating what's called a motor map. Now, this gets us to epilepsy. And why would we want to have a technique like this in a clinic for epilepsy? Well, it's for one of a couple of reasons. The one that's actually becoming most common is in functional mapping of the motor cortex. That is especially in pediatric epilepsy, where a seizure focus is more likely to be neocortical and has an appreciable likelihood of overlapping with the motor system. We want to ask before surgery 2 big questions. One is, where are the seizures coming from? And 2 is that part of the brain good for anything? And so in asking, is that part of the brain good for anything questions, we would like to then have practical mapping of the motor cortex in advance of epilepsy surgery. And this is in fact how we use transcranial magnetic stimulation in our hospital most often. We use it for lots of other purposes, but more often than not, what we're doing is mapping the motor cortex in an individual by visualizing where we've stimulated in that individual and recording the EMG signal that comes out of a plurality of muscles from that patient. Again, what we're talking about is recording the surface motor evoked potential by skin electrodes that can be easily adhered. In this case, this is the electrode sitting on the abductor pollicis brevis muscle, and we can record, as you can imagine, from lots of other muscle groups. Here are examples of very young participants. I should say that both of these mothers gave a consent for these babies to have their photos shown. This is a boy who's coming for focal motor mapping in advance of surgery for his focal cortical dysplasia. And you can see the electrodes to record the motor evoked potential after we identify the patient's motor cortex. This is actually a healthy participant, a control, in a study that we had on hemiplegic cerebral palsy. And you can see here that we're recording a signal from the patient's deltoid and the patient's intrinsic hand muscles. And so for purposes of mapping in the pediatric epilepsy centers in particularly navigated TMS, that's what the letter N here is for, has fallen into an interesting niche. And this is because in pediatrics, the seizure onset zone is more likely to be neocortical and has a greater likelihood of overlapping with the motor cortex. And so we have to ask the question of where is the motor representation in an individual before surgery. And then, although in adults, we can often ask questions about the functional map by functional MRI or WADA or other techniques, children do not cooperate with the functional MRI and have to be sedated for the technique, whereas children can be conscious and not really disrupted appreciably by TMS. And then there is an element of physiology in the developing brain, and that is a high motor threshold. That is that the amount of electrical current that it takes to activate a pediatric motor cortex is considerably greater than it is for adults. And for that reason, intraoperative motor mapping is impractical in many cases of pediatric surgery. I should say this goes not for epilepsy just, but this also goes for tumor surgery. And again, a pediatric tumor is more likely to be, well, a pediatric tumor may be supratentorial and can also, of course, go not just for pediatrics, but this is also relevant for adult functional mapping. And so just in quick summary, what we're doing when we're using TMS for motor mapping is we are discharging a capacitor through an electromagnetic coil. We're generating a magnetic field. That magnetic field induces an electrical current everywhere around it, including in the brain if we position it over the scalp. And if we position the stimulator over the motor cortex, then the brain talks back to us rapidly in the form of a motor evoked potential, which we can quantify. Now, I should say, as a quick scientific aside, we are often in lots of disease states and research studies interested in how excitable is the brain, or how intact are the brain's inhibitory mechanisms, or how plastic is the brain. That is, could we measure events such as long-term potentiation and depression, measures of synaptic plasticity in the brain? And this enables us in a human who's awake and cooperative to do what we can also do in slices of brain in vitro. That is, we can generate an input-output curve and measure excitability and plasticity. The input-output curve corresponds, of course, to the strength of this magnetic field and the amplitude of the motor response. So this is my long way of saying that TMS is unique among brain stimulation technologies in that it avails to us not just a therapy, potentially, but also a very interesting access to the nervous system for diagnostic purposes. Now, in quick summary, any kind of brain stimulation, including TMS, can be divided into roughly 3 kinds of protocols. Single pulse stimulation, where we stimulate the brain once and we wait for an evoked response that we measure. Or an interesting technique that I hope to talk about if we have time, called paired pulse stimulation, where we stimulate the brain initially with a single stimulus and very quickly, within milliseconds, follow it with a second one. And after the first stimulus, termed a conditioning stimulus, the response to the second stimulus, termed a test stimulus, is never the same. And this enables us to stress the brain to measure how intact or how disrupted is GABAergic cortical inhibition. And in a disease like epilepsy, where there's a paucity of inhibition, as you can imagine, and where inhibition we want to restore, for example, with drugs, this becomes an important way for us to test this kind of cortical capacity. And then there's repetitive stimulation, which enables us to actually change how excitable the brain is, or to alter. So let me focus on these in some sequence, and I'll focus on single pulse stimulation. Oh, I'm sorry, is there a question? Oh, I'll just move on, I guess.
Yes, you can move on, please.
Okay. So again, what is the common use of TMS for us for pre-surgical mapping? It's something like this. You could see a stimulus delivered to this patient's brain. You can see the ring-enhancing region for this patient that is in the proximity of the motor cortex. And we're asking for tumor surgery whether or not the motor cortex overlaps with the lesion.
It's well inside the line of the ball away
this
from
is an
where the bounce is
example
going, moves towards the soft
of
stop.
what we typically produce when we have a patient in our clinic for motor mapping. This is the brain of a 4-year-old. and you can see the central sulcus. You can see the stimulus is delivered at the junction of the red and blue arrows. And these color-coded dots correspond to where we had this kind of deflection, which is a motor evoked potential selectively in the right abductor pollicis brevis muscle, whereas 5 other channels of EMG recorded from 5 other muscles are silent. So you can get a sense of the focality of the stimulus, perhaps from this graphic. That is that we activated selectively the abductor pollicis brevis without activating the deltoid or the tibialis anterior or other muscle groups. And so after we've activated a selected muscle group, what we can do is then generate a product like this, which is termed the cortical motor map. That is, in color codes here, we have a range of amplitudes of the motor evoked potential, so we can say the intrinsic hand muscles for this patient are represented in this area. Just like we can map the hand muscles, we can also map the foot, and you can see in the same patient where the tibialis anterior is mapped, and you can see again, just to orient you, the central sulcus, and this is the superior aspect of the precentral gyrus. And so we're able to produce a map of the hand, the foot, the shoulder, etc. And what is the practical purpose of this? Well, it's something like this. Here's a patient of mine. This is a teenager with a low-grade glioma, which you could see it's actually effacing the precentral gyrus, is just underneath the motor strip. And so we're able to, by measuring the amplitude of the motor evoked potential, map the first dorsal interosseous muscle for this patient to get a map of the intrinsic hand muscles. For the same patient, we can map the tibialis anterior muscle. And then we can put these maps together to identify a corridor between the foot motor representation and the hand motor representation that the surgeon can go through and not disrupt the function of either limb, which is in fact what the surgeon did in this case. And this patient did very well in terms of motor deficits. She was able to drive a car and dance, etc. And so this is the practical value of what we do with non-invasive motor mapping. But we can learn some things about other mapping techniques and about physiology of the brain by doing this kind of mapping. So let me walk you through an interesting other case. The arrows in this case point to where we stimulated in this patient. What you can see is already a very abnormal hemisphere. This is a patient who was headed toward hemispherectomy because of an intractable epilepsy. And we asked 2 questions in this case. Is there bilateral hand representation in the good hemisphere? And is there absent hand representation in the bad hemisphere? Which is a common question for us to ask. And so, when we stimulate this patient's contralesional hemisphere, what we see are 2 distinct motor responses from both the left hand and the right hand, from the left first dorsal interosseous and from the right. There's an interesting aside to this map, which is that you could see where the stimulus has landed relative to the central sulcus. We were able to produce this bilateral motor response by stimulating the post-central gyrus, not the precentral gyrus. So one of the other interesting things we learned just by doing motor mapping as a matter of routine by TMS is that the Penfield homunculus, that classic cartoon that we see that shows the motor and sensory cortex as 2 distinct entities, is in fact just that. It's a caricature. And realistically, there is overlap of the sensory and motor systems in almost every human. We're not the only ones to see this. This is Harry Shigani's work from many years ago, showing that if we look particularly in healthy teenagers, we can often find a cortical spinal tract behind the precentral gyrus cortical spinal tract. That is, the post-central gyrus often contains a few motor fibers. And this is a map from one of our patients, again, with the central sulcus here, showing a post-central motor representation. So back to this patient, then sorry for that scientific aside. We can see in the bad hemisphere that a stimulus produces nothing but electrical artifact. There's no motor response, which would otherwise be here. Now, what's interesting in this child is that he was cooperative enough to go for an awake functional MRI. And in the functional MRI, I'll just point your attention to the bottom right panel, we saw something interesting. That is that we have a conspicuous bold signal on a left-hand tapping task. So now we have a discrepancy in this patient. It's an interesting case because we have, with electrical stimulation by TMS of a lesional hemisphere, we have no signal. But by fMRI, we have a preserved signal. And it turns out that this patient went on to hemispherectomy and had no difference at all in his motor exam, notwithstanding this positive motor map by functional MRI. We're not the only ones to see this. Other groups, this is the work of Martin Stout in Germany, for example, also see that when there is a present signal on fMRI but an absent signal on TMS, the TMS is a better predictor of the likelihood of motor injury after surgery. And now there's any number of physiologic reasons for this. One is, of course, that the fMRI is a vascular signal. It's ultimately a surrogate for what the cortex is doing. The other is that the motor signal on fMRI, on functional MRI, is never purely motor. That is, that there's necessarily some proprioceptive sensation and somatosensory signal that mixes with the motor signal. Whenever we move a limb, we feel it move. And that signal can be bilateral and is uncoupled from an intact corticospinal tract. But whatever the case, it turns out that TMS, in instances of surgical planning, is a better predictor of the risk of injury to the motor system than the fMRI. Now, let me show you another kind of mapping, which is mapping not the motor system, but the language system. In other words, when we are contemplating epilepsy surgery or tumor surgery, we want to make sure that just like the resection will be appreciably away from the motor system, it'll be away from the language system as well. So let me show you the basics of how we map the motor system, the language system. And let me show you what's happening in this monitor. What's happening here is that this participant is looking at a screen. The screen is flashing these items. You can see an arrow, binoculars, flower, and the operator, in this case it's me, I'm manipulating a coil to what I think is pars triangularis of the left inferior frontal lobe, the Broca's area. What the stimulator is doing is delivering short trains of stimulation at 5 hertz to interrupt language. So please tell me whether or not this works. This audio works variably on Zoom. But I'll show you what happens with this patient. So you can see that he sees an arrow and he says arrow. So you can see that he says arrow, he says binoculars, and when it comes to the flower, he says nothing. By then I've advanced the coil a little bit, but he smiles when he sees the flower, so his face is not paralyzed. I'll play it again. And of course, you know, the flower and the control condition. And so I hope the audio came through, but what you saw for 1 second when he saw a picture of a flower and couldn't say it is a Broca's aphasia. He had a short-lived expressive aphasia, and just like we can map the motor system, we could map the language system and ask ourselves, where in the brain do we have to stimulate to interrupt language? And very much, in fact, like we have a discrepancy between the fMRI and motor and fMRI and language, we sometimes see an fMRI and motor mapping by TMS and fMRI motor mapping. We can sometimes see a discrepancy in the fMRI language map versus the TMS language map. And here's one of these examples. This is a patient with a left frontal cortical dysplasia, where the Broca's area activation on an fMRI task looks to be in the right hemisphere. But although we find it in the right hemisphere by TMS, we also find it on the left. And in fact, and you can see the patient's actual cortical dysplasia that had to be resected around this language representation. And so, in fact, when we look at comparisons from our series of whether or not the fMRI or TMS predict language better, it turns out that when we have a discrepancy, particularly when the functional MRI shows right hemisphere language mapping, the TMS looks discrepant in 5 out of 6 instances. That is, that when we see the fMRI point to the right hemisphere, more often than not, TMS motor mapping, which is a more intimate mapping, it's a little bit more like intraoperative language mapping, will show a language map either in the bilateral hemispheres or in the opposite hemisphere, in the left. So I hope that makes sense, and please feel free to pause me if it doesn't at some point. But the practical implication here is just like there is a discrepancy between the TMS motor map and the fMRI motor map, there is sometimes a discrepancy between the TMS language map and the fMRI language map. And when there is such a discrepancy and we have a tiebreaker diagnostic like a WADA or surgery, it turns out that TMS could be a better predictor of where the language is in an individual. So let me quickly then move to other stimulation protocols, particularly this repetitive stimulation that can interrupt function or change cortical excitability. Now, very much like we saw Broca's area when stimulated, disrupted, so the patient had disrupted speech, one could ask, will this kind of stimulation disrupt ongoing seizures? And we've looked at this in a few epilepsy conditions, including epilepsy partialis continua and other forms of status epilepticus. And here's one example. This is a 47-year-old patient with epilepsy partialis continua. And you can see this patient's persistent spikes in EEG. And then after a train of stimuli, these are the vertical hash marks of where the stimulus was delivered, the spikes resolve. It turns out that in our first series that we published already more than 10 years ago, when we looked at epilepsy partialis continua in just a very small patient population, in about 1/3, the seizures aborted after we applied trains of repetitive stimulation. Since then, we've done dozens of patients, and our statistics are about the same. About 1 in 3 patients have a very favorable response to stimulation. Their seizures break. Now, this is, of course, for ictal stimulation. What can we do to disrupt ongoing seizures? And in epilepsy, of course, there's 2 places to deliver therapy, ictal and interictal. And so for interictal stimulation, there are groups that have tried to deliver low-frequency repetitive stimulation over the seizure focus. And this could be relatively focal stimulation using that figure of 8 coil, so we can deliver stimulation precisely to the seizure focus. And the rationale for using low frequency is exploiting a basic phenomena of any nervous system, including human, which is that if stimulated at a low frequency, somewhere between 0.5 and 1 hertz, the strength of excitatory synapses declines. This is the process of what's called long-term depression of excitatory synaptic strength. This is actually the subject of, I think, year 2000 Nobel Prize. When one delivers repetitive TMS at a low frequency, one can depress excitability over a seizure focus. And this has been tried in a few trials. This is the trial of Wei Sun, who we were lucky to have in our laboratory for some time, a few years ago in Beijing, where we have a group of sham-stimulated participants and active stimulation, where one can see an appreciable decline by as much as 90% in seizure frequency in participants who received Verum stimulation. Now, let me walk you through some of these abbreviations. RMT in this case is the unit of stimulation strength in TMS. RMT refers to the resting motor threshold, which is the amount of energy, the fraction of the capacitor that you need to discharge to produce a motor evoked potential in a limb. And so these are the units of power that we use for TMS. And you can see that all these patients have at least several weeks of seizure relief after stimulation for 2 weeks of daily sessions, 30 minutes per day, I think, of low frequency repetitive stimulation. We've tried this as well in a few patients. This is a specialized kind of electromagnet that wraps around the head and induces electrical current deeper in the brain, so it can reach the mesial temporal structures. And in a recent study of mesial temporal lobe epilepsy, what we found is in the Verum treated group, about a 50% seizure reduction and nothing in a placebo-treated group. Now, let me show you the glass half empty, which is that for an individual, even though the average could look like a 50% seizure reduction, if the columns here on the y-axis correspond to the number of seizures per day, and they pause for 2 weeks that we deliver daily repetitive stimulation, they relapse pretty quickly. And so notwithstanding that data like this can make for a good graph, and we can be self-congratulatory, as we often are in epilepsy, by a reduction in seizure frequency, this patient still can't drive. And so we have to ask ourselves, how do we improve? Well, we can try to improve in humans by doing what we do, but more of it. And this is a very common pitfall in many organizations, in everything from science to medicine to the military. That is, if something doesn't work, you just do more of it and do it harder and don't quit. So here's one of our examples. Here's a patient where after 10 sessions of TMS, the seizures declined, but didn't go away. So we said, let's do it harder. And so we tried 15 sessions of TMS and the seizures still didn't go away. Then we tried 30 sessions of TMS and seizures still didn't go away. And so the do it more and do it harder philosophy may be valid in one of few instances, but ultimately one needs to understand when to retreat and regroup and think through how to reformulate one's approach. And in humans, this is very difficult because patient volume is limited. The mechanism of disease, the drug exposure, et cetera, is quite variable in patients. They're necessarily inhomogeneous, and large numbers to look at hundreds of seizures or hundreds of participants are impossible in humans when we're dealing with non-invasive brain stimulation, or for that matter, any other kind of intervention in epilepsy. So for many of our perspective, the way to improve is to reduce this to a preclinical setup. And this is one of these preclinical setups. This is a figure of 8 coil that we Mickey Moused ourselves for stimulating a rat. And you can see the wires recording this rat's EEG and cardiogram. And what we can do in a setup like this that we can't in humans is trigger seizures on demand. And so in this case, this is a graphic showing a seizure triggered by cyanuric acid, and then deploy a train of stimulation. These are the vertical artifacts to see if we can abort the seizure. Now you could ask, what's so good about doing this in rats when we could do this once in a while in humans? Well, the value of doing this in rats is that we can look at hundreds of seizures and systematically march through the parameter space. That is, that in humans, to compare 0.25 hertz with 0.5 hertz with 0.75 hertz with 1 hertz, et cetera, would take years and years. In rats, we can look at hundreds of seizures and compare a range of low frequencies to say, you know what, 0.25 hertz doesn't work to stop seizures. And the closer we get to 1 hertz, the better is the seizure response. And this way, we can readily translate what we do in animals to humans. We can do a number of other things in animals. For example, like we can test how to combine drugs and devices, or how to identify drugs that a participant may be on that would get in the way of therapy. And then we can do something else in animals that we can also do in humans. And that is, we can again take advantage of TMS over the motor cortex, specifically over the motor strip, and record the motor evoked potential to measure how excitable is the brain. So again, just to review, this is the abbreviation that we came across earlier called the resting motor threshold. If we stimulate at 33% maximal output of the stimulator in this individual, we don't get a response. 34%, we don't get a response. 36%, we get a response. So we say the threshold is 35%. That's the measure that we use to identify how easily excitable is the brain. And again, this is that input-output curve that's available to us by TMS that's otherwise unavailable to us in humans. And along these lines, what we can measure in humans and in animals is this GABAergic inhibition. So I mentioned this before when we talked about paired pulse stimulation, but this is a graphic illustrating it, where we have 2 consecutive stimuli depicted by the artifacts here, producing 2 motor responses. And if we do this, and they're separated by 50 to a couple of hundred milliseconds, the size of the second response is never as big as the first. It's predictably smaller because the conditioning stimulus, when it lands on the cortex, activates not just excitatory neurons, it necessarily activates an inhibitory surround. So when the second test stimulus lands, it's landing on an inhibited cortex. And the ratio between these 2 responses can give us a measure of how intact is GABA-mediated cortical inhibition. And as you can imagine, in epilepsy, that's a big deal. So much like we can do this in humans, we can do this in animals. Here's one graphic showing a stimulator, a rat. In this case, we're recording what's called the mechanomyogram, and not the electric myogram, but the magnitude of the displacement of a limb from an animal, which is easier than EMG. And we can see that 2 consecutive stimuli can be delivered to an animal, and the size of the second response is never as big as the first. So if we put these into a ratio, we can measure how intact is cortical inhibition. That is, if the denominator is the second, is the first of the responses, the numerator is the second, the lower this value, the more intact is cortical inhibition. A value of 1.0 means that there has been no inhibition of the second motor response. Now, what's so good about this, and what can we do with it in animals, and what can we do with it in humans? And so just as a quick aside, I should mention that about half my laboratory works on traumatic brain injury and post-traumatic epilepsy, which is actually the most common way for young adults to acquire epilepsy. And the unfortunate natural experiment that happens in post-traumatic epilepsy is that there's often an injury, to a young and healthy brain. And after that injury, nothing happens for weeks and weeks, if not in months and months. And then the patient develops epilepsy. And the question for us, for many of us in the field, is what is happening during this time that we can interfere with? That is, what is happening during this latent period between injury and epilepsy that we can A, identify, and B, treat? And this is a lot of what my laboratory does. We look at the mechanism of epileptogenesis rather than epilepsy, and we ask ourselves, can we identify what the mechanism is? Can we find a biomarker to tell us that this mechanism has started? And can we identify ultimately a treatment? Now, we can model post-traumatic epilepsy in rats with something called a fluid percussion device that delivers a pressurized wave of fluid to a dura in an animal that's had a small craniotomy, and that creates a cortical contusion and a mix of dying and surviving neurons. This is what's shown here with something called a fluorogate B stain. And then in 6 weeks, EEG seizures that one could very easily detect. Now, in this period in a rat between injury and epilepsy, one can ask by TMS, what's happening to GABA-mediated cortical inhibition? It's a reasonable hypothesis that among the things that are changing during this period of epileptogenesis between injury and epilepsy is a progressive loss of inhibition. And what Henry and Sean, our postdocs, did was injure rats or provide sham injury to rats and measure this paired pulse inhibition. Again, you can see the response from the first TMS pulse and the second response is smaller. And in sham injured rats, that second response remains smaller. But in a injured rats, although this response starts out smaller, there's its progressive growth. So by the 6-week time point, when the animals develop epilepsy, there's no longer inhibition of the second of the two motor responses. So if we plot on the y-axis this ratio of the two responses, so the lower the y value, the more GABAergic inhibition there is. The higher the y value, the more loss of GABAergic inhibition the animal experiences. And we injure the animals, and every week for 6 weeks while they develop epilepsy, we ask, how's your cortical inhibition? How's your cortical inhibition, etc. What we can see is in the injured group a progressive loss of cortical inhibition. Now, the value of doing this in animals, even though we can do it in humans as well, is that we can look at the organ in question. We can look at the brain and ask what's happening. And it turns out that if we look at neurons as a whole, we don't see any change in the brain during the 6-week period. But if we look at a specific neuronal type, and I'll point out this neuron for the group because it's a hot neuron to look at, something called a parvalbumin positive inhibitory interneuron. It makes up about 40% of all GABAergic cells, and it's an extremely delicate interneuron, in part because it's firing all the time. It has a very high metabolic demand. And because of that, these cells die if you look at them wrong. And in episodes of hypoxia, hyperthermia, trauma, infection, one could have a preferred loss of these neurons with other neurons staying intact. And that gives us this shift in the excitation inhibition ratio toward a depression of inhibition. And this is indeed what we see. So at the same time that by TMS, we lose cortical inhibition, in animals, what we see is a loss of parvalbumin over time. That's what's shown in the middle graph, for example. Around the lesion, we have a loss of these parvalbumin positive cells. Now, I won't bore you with the details of why they are lost, but I'll just mention that some of this has to do with a progressive increase in oxidative stress after head trauma that we see in mild and severe brain injury, a progressive erosion of the extracellular matrix around these cells, something called a perineuronal net. And the reason for this, we hypothesize in the laboratory, is that what happens after injury is that not that the neurons dysfunction, but astrocytes, once we have reactive astrogliosis after an injury, lose by about 50% the major glutamate clearance mechanism from the synapse, something called GLT1, the glutamate transporter type 1, or in humans, the excitatory amino acid transporter type 1. And then what happens when the astrocytes lose this protein, this GLT1 protein, is that there is an excess of glutamate in the synapse. If there's an excess of glutamate in the synapse, then a glutamate cysteine exchanger, and I apologize for this boring biochemistry, but I promise it gets back to TMS in a second. This glutamate cysteine exchanger malfunctions so that there's no longer adequate substrate to make glutathione, which is the major endogenous antioxidant in the brain. And without adequate glutathione, then there is this cascade of injury. there's oxidative stress, there's erosion of perineuronal net, and then there's loss of progranulin cells, and eventually a loss of cortical inhibition that we can see by TMS. Now, it turns out that this glutamate transporter loss is a druggable target. And for reasons having nothing to do with their antibacterial properties, beta-lactam antibiotics like ceftriaxone restore the amount of this glutamate transporter. And that, after brain injury, corresponds to reduced astrogliosis and reduced seizures after trauma. Now, sorry for this rabbit hole of biochemistry. And the question is, why is this at all interesting to a TMS lab? Why would we want to have people who do this for a living look at astrocytic glutamate transporters and their modulation by beta-lactam antibiotics? And the reason is that in studying not epilepsy, but epileptogenesis, we can identify between the time of the insult and the time of epilepsy several steps that have to do with glutamate release and glutamate clearance and oxidative stress and loss of provalbumin. And many of these may be druggable. There may be pharmaceuticals that could be deployed at any of the stages of epileptogenesis, not to treat epilepsy after head trauma, but to prevent epilepsy after trauma or cerebral malaria or stroke or other disorders that have a high likelihood of triggering epileptogenesis. And what's absent is a biomarker, not for epilepsy, but for epileptogenesis, the kind of biomarker that tells us that this cascade has started in an individual, and the kind of biomarker that tells us that this cascade has been reversed by a treatment, because otherwise the entirety of this process is invisible to the naked eye. And so what Mustafa Hamid, our postdoc, did was an experiment just that. We injured animals. We treated animals with ceftriaxone or with saline. And then we measured by paired pulse TMS this ratio of the first to second motor response in a paired TMS protocol to ask on the y-axis, what happens with treatment after something that's anti-epileptogenic versus after placebo? And although graphically this may not be very impressive, intellectually for us, this was a big deal, because for the first time, we can see that the ceftriaxone treated group with the dashed line has a preserved cortical inhibition. That is, that in this period that's otherwise invisible to us, this period of epileptogenesis when seizures develop slowly, a treatment can prevent this expected loss of cortical inhibition. And of course, in animals, we can confirm that not only did we prevent the loss of cortical inhibition by TMS, but also we've salvaged this provalbumin cell population. And so that's my quick way of saying that TMS has a value to us in both the clinical and scientific arena, and both as a therapeutic and as a diagnostic, which makes it unique among brain stimulation technologies. So I'll close with one more slide about one of the earlier attempts to induce electrical current in a human to see if it does anything to the brain. And this is an image of Jacques-Arsène d'Arsonval, a French physiologist who worked from the late 19th century till 1940 when he died. This is an attempt to induce electrical current in an individual, and this individual, in fact, saw sparks and became and experienced vertigo. And this was the first proof that induced electrical current could modify the brain. But what's interesting in this figure is not the photo of the first TMS device, but who are these individuals? And the fact is that this is the laboratory technician running the equipment. This is actually the postdoc who is quite happy, I think, you can't tell by this photo, to volunteer himself for this experiment. And this is the lab PI standing off to the side and taking credit for everything. And so since I've been showing laboratory data, please let me promise you that I've done none of it. This is all completely the credit of our excellent team of young investigators in the laboratory, and I'm just honored to be showing their data to groups. Everything you enjoyed about this talk is completely the credit of these investigators, and everything else is mine. So thank you very much.
Thank you, Dr. Rautenberg. Dr. Jacob, are you there? Okay, that was an excellent deliberation regarding TMS. I'll hand over the. Is Jacob? Can you take over the session?
Yes,
Thank you.
Dr. Joban. Thank you, Dr. Alexander Rothenberg. That was an amazing session. We were really glued to our seats, and every part of it was truly a revelation. Thank you so much. And
My pleasure.
yeah, and we heard from you earlier that you're fascinated with India. Next time you visit India, I'm very, very sure that you're going to visit our institution. We'll ensure that.
My pleasure. I hope to see you one day in 3D.
Absolutely. And thank you so much, Dr. Joban and
You got
Dr.
it.
Sujin, for coming over for the session and moderating the session quite admirably. Thank you so much for your time too, and special thanks
Perfect.
to all the participants who have come over. I hope you had an amazing session, probably one of the best sessions we have had so far. And hats off to Dr. Alexander for that.
Thanks a lot, guys. All the best. Take care.
So have a blessed evening until we come back with another impactful session.
Jacob, I would like to interrupt. Can I have a few questions? I think it is a bit.
Absolutely.
If Dr. Rothenberg does not have a problem with that, can I have some queries?
Oh, of course. Yeah.
Okay. I just noticed that there may not be much queries from the audience because it's a reasonably advanced topic that you are dealing with, because we are not much into these things. We are solely based on medical treatment of epilepsy only. So some doubts I have. One is regarding the bilateral motor response confined to one hemisphere. Is it because only the other hemisphere it is diseased, and due to plasticity, both sides is being managed by one hemisphere?
It's a very interesting story, and so I'm happy to share my. Well, I can explain it without sharing a graphic. Realistically, we are born with either hemisphere connected to both sides of the body, and through about age 2, the ipsilateral connections are gradually suppressed in either hemisphere. And so if we were to do TMS over the motor cortex of a newborn, we would see a bilateral limb response. And through about age 2, that lateralization then becomes conspicuous, so that by a 3-year-old, we see nothing but a contralateral response. But if there's an early life injury to a hemisphere, an early life stroke, it is a form of plasticity, but it's not that the good hemisphere gains control, is that the good hemisphere doesn't lose its immature ipsilateral corticospinal tract connectivity.
Okay, thank you. Another thing is regarding focal epilepsy, many of the times we manage with 1 or 2 drugs in succession, the seizure gets controlled. In some cases, it is difficult. So at what point do you consider TMS in focal epilepsy? Like you have tried all the medical...
It's usually far after 2 drugs. And so for focal status epilepticus, we're sometimes called into the ICU for patients with epilepsia partialis continua, usually after 5 or 6 drugs. Realistically, we ought to know that pharmacoresistance in epilepsy is evident by drug number 3. And so we start thinking, we're trying to think more and more about non-pharmacologic treatment of epilepsy, which could be neuromodulation or surgery or variations of the ketogenic diet by drug number 3.
Okay, and regarding at which focus, if my terminology is right, at which focus should you apply the stimulation? Should you first localize from which place the seizures are arising, and then...
Yes, if the seizures are not well localized, TMS doesn't work.
Okay. Okay. And regarding the paired TMS, do you think that it is not recommended to empirically start? That is what I believe. We are not supposed to start anti-seizure medications if the patient does not have seizures in post-traumatic cases. So do you think we should do a paired TMS if the facility is available? Do you recommend these in all cases so that we can find out ultimately who is going to develop a post-traumatic seizure?
I think that there's two replies, at least from me, that the two thoughts come to mind. One is that should we try prophylactic medication after traumatic brain injury? It has been tried with phenytoin, with valproate, with gabapentin, with levetiracetam. It doesn't work. Realistically, we need to reconsider what medications to try. Conventional anti-epileptic medications do not prevent epilepsy. Other medications may, statins, beta-lactam antibiotics, etc. That they address the biology of what's happening in epileptogenesis rather than the biology of epilepsy. Now, whom to treat with this and whether we could identify in whom this process of epileptogenesis has started, as you say, could be identified by TMS. This is an experiment we're dying to do, that we're actually just at the point of drafting right now. And if you wish to collaborate with us, we're looking for collaborators all the time. The simple experiment we would like to do after a number of injuries, one that we're considering strongly is cerebral malaria, and another one is trauma, is to identify a cohort of patients of whom 10 to 20% will get epilepsy and follow them by paired pulse TMS for 2 years. And then see who of those develop epilepsy and whether or not an early TMS signal could predict who is headed toward epilepsy, and that person perhaps should receive some kind of prophylactic treatment.
And another query is regarding the duration. What was the duration of ceftriaxone that you used in all these experiments?
Well, by default, we use 1 week.
Okay, at a dose of
meningitic doses.
Meningitic doses. Okay, and I will end by one more regarding the infrastructure for this. There are a large number of uses, upcoming uses of TMS. Even the psychiatry people are using it for treatment of many of the psychiatric conditions. And there are many applications for TMS. Is the same infrastructure required for all these cases, or you need to have separate devices and for various indications?
It's better to have
dedicated
2 devices that are dedicated, but it's not necessary. In other words, these days the technology is pretty versatile. We are constrained a little bit in the United States by what we can bill, quite frankly, by the Food and Drug Administration clearances. But realistically, one could set up a TMS laboratory with a single device with a range of coils and a portable navigator, so that you can do it all. You can use it for treatment of major depression. You can stimulate it to identify the motor cortex. You can do it for treatment of epilepsy. And so it is, these days, not that difficult to have a TMS setup that's quite versatile and will work in a range of disease states.
And one more regarding the learning curve of this for a neurologist who is willing to take up the
I promise you it's easy. It's so easy even I can do it. So we teach a course, for example, 3 times per year, an intensive course at TMS where we have international students all the time. They're physicians and scientists overwhelmingly. And that takes about 5 days of about half day didactic, half day hands-on. And usually at the end of these 5 days, most participants are pretty comfortable. And so one can imagine spending a few days in a course and a few weeks in somebody's laboratory to just become familiar with the nuances of TMS and then doing it on their own.
Okay, thank you for your responses. And yes, Dr. Jacob, you can please continue.
Yeah, there is one more question from one of our participants. Can we use TMS in all types of epileptic patients? For example, a patient with cardiac pacemaker.
The answer is probably. When we've tested TMS explicitly on electronic devices, it turns out that most electronic devices withstand TMS. There are, however, some contraindications, and I think what has to be weighed is a risk-benefit ratio. The induced electrical current, realistically, drops off as a cube function of distance from the coil. And so by the time we reach the chest, the amount of electrical current is trivial. And so the electricity itself should not interfere with the pacemaker, and it's unlikely that the coil will slip to the patient's chest, but it's not a zero risk. And so the physiologic answer from my perspective is yes. The regulatory answer has to be institution and regulatory body specific.
Thank you.
Sorry for the vague answer, but that's how it is.
Thank you, doctor. Doctor, one more question actually.
Yeah.
Is there any other, comorbidities like we cannot use TMF?
Well, interestingly enough, in patients for whom TMS is being used for major depression, if they have a very fragile epilepsy, that could be a contraindication, because high frequency repetitive stimulation, which is what's used most often for treatment of major depression, can, even in healthy volunteers, provoke seizures. Now, the probability of that is less than 1 in 10,000, but the probability of triggering seizures in somebody with epilepsy by TMS is between 1 and 2%. And so sometimes, depending on the condition, a vulnerability to seizures can be a contraindication. Intracranial hardware can also be a contraindication. But having said that, we've been asked to give an opinion, for example, a few years ago on a patient with an aneurysm clip who needed TMS for major depression. And this patient, I understand, had TMS. It wasn't in our institution, but did well. But you can imagine responsive neurostimulators, some others would not cooperate well with TMS. Vagus nerve stimulation is acceptable with TMS from my perspective. And so I would say that intracranial hardware should be by default a contraindication until it's looked at explicitly. Extracranial hardware should not be a contraindication by default, but that should be addressed with the local regulatory body. Specific disease states, for the most part, are not contraindications. I'll tell you my bias, which is I've stayed away, even though we've been asked to look at TMS in mitochondrial disease. And the reason for that is that the metabolic reserve in mitochondriopathies is already limited. And if we were to drive neurons to fire more than they have to, you can imagine exhausting that reserve and perhaps causing an injury. And so that's the one disease state that we've stayed away from.
Thank
Okay,
you.
thank you, doctor.
Yeah,
Of course.
Question. And thank you, sir, for responding to that in positive. And yes, you spoke about collaborating and doing research with our institution. We'd be more than happy to extend our hand in whichever way possible so that we can collaborate. And
oh, we collaborate with everybody. So by all means, you have my email, and I'm happy to talk about ongoing studies that we have, and not just with TMS. We're also working with other technologies, and we're delighted to collaborate.
Yes. So I think both Dr. Joban and Dr. Sujin will be excited at the prospect of collaborating. Dr. Joban, would you like to say something?
Yes, definitely, we will look into that, and we'll be in touch with you regarding the possibilities of collaborating with your institution.
You got it. Okay, everybody. All the best. Thank you very much again for the opportunity to talk.
Thank you so much.
Bye-bye.
Thank you. Thank you so much. I would like to once again thank our speaker, Dr. Alexander, for coming over and giving us this brilliant session, and our moderators and our participants as well. And let me quickly tell you something. This is a venture or an initiative by our institution, the Believers Church Medical College and Hospital, to try and reach out to all the medical students of this country who do not have access to quality sessions from amazing faculty across the world. So this we are doing. We have reached out to around 30 to 40 medical colleges across the country. We want to do more. We want to reach out to all the medical students in the country. And by liaising with a great faculty like Dr. Alexander, we will be eventually able to hand these sessions free of any cost to all our medical students. We should be having around 5 lakh medical students at any point of time. That's 500,000.
Oh, that's terrific. Happy to help.
500,000 medical students across the country. This is our dream, and we are walking towards it. So it would be great if you all partner us in this. Try and reach out to other medical students and tell them that this is what we are doing. We would like to reach out to them and bring to their own devices wonderful speakers like Dr. Alexander from Harvard Medical School. With this note, thank you so much, Dr. Alexander.
All the best. Thank you.
We would be in touch with you, and we would look at all avenues to try and collaborate with your great institution, the Mecca of medicine.
That's very kind. Thank you.